Welcome to Sairam Academy. We are back after a long gap. Um, Today we are going to see some expert opinion regarding evidence-based practice, because we thought that there will be a lot of apprehension when you are asking questions on a common forum regarding evidence-based practice, which can be a major obstacle for you in practicing evidence-based practice. So what we did was we asked for questions on Facebook and email. We received some questions from many participants, enthusiasts, and we also added some questions from our side, which are the basic questions which are asked from a beginner's point of view, or people who are really willing to practice evidence but have a lot of obstacle or apprehension towards doing the same. So these questions we have framed and we are asking to some of the experts who have been in this field of evidence-based practice, who are educating this for years together, more than we answer these questions. So we have selected 3 people and we are coming up with some more people. And I would like to start this program with the pioneer in this field of evidence-based practice, Dr. Hariohm sir, who to my knowledge has been educating evidence-based practice and its values for more than 2 decades for now. Sir, good afternoon. Thank you for coming up for the program once again, sir. Sir, we have 6 questions today. The first question will be, sir, how to keep in touch with the recent trends? Because science is an evolving phenomena. So the new updates keeps on coming. And as a physiotherapist, a clinician who is practicing, he can spend only a little amount of time for reading means. Where to look into these updates? Can you give us an idea?
What I would suggest is, if you, for example, if you're a clinician, I will always tell that read systematic reviews. Say, for example, systematic review on exercise for back pain or things like that is the best way to keep up with the updates, right? And luckily, in case of physiotherapy, it doesn't change drastically. Say, for example, we are not going to say that this drug is harmful or it doesn't completely work. As you can imagine, in the COVID time, they started with, everybody thought that hydrochloroquine will be a better drug, and the evidence came and it sort of said that it is not working at all, or it may be harmful. This rarely happens in physiotherapy. Sometimes what happens is you can start the treatment earlier based on the surgical intervention, or in the ICU. Say, for example, when we went to college, early mobilization in the ICU was not that big a deal. Now it is an important thing. So if you read that early mobilization systematic review once, afterwards keeping up with it is slightly easier. Once in a while, you can just go into PubMed and just type in early mobilization for ICU patients, and you may get after 6 months, you may get 1 or probably 2 maximum of RCTs. So it's fairly simple to keep up. But I would suggest the first time you need to read the systematic review very, very clearly. Right.
Sir, in case if I want to know the authenticity or the physiological background of a new intervention which is being introduced, say, for example, we can say a virtual reality.
Right.
So how should I systematically approach this condition? A new intervention.
I understand. I have a very simple approach. Start with whether it is active or passive. That is, whether the participant is just receiving the treatment or he is actively participating in that. And if he is actively participating, most of the time it's better. The next thing I would suggest is it, even if in case of virtual reality, right? Is virtual reality better than reality? That's the question I would ask. So if reality is as good as virtual reality, I will be like, why do I need a virtual reality? Is it just a gimmick or is it just a really, really useful thing? And at the same time, I will also look into the cost part of it. How much of it will it cost to change my practice from uh, the practice what I am having now to the newer intervention, if you will. So if it costs me to set up half a crore or 50,000 uh, 50,000 to 50 lakhs, I will make a decision in accordance with that also, because uh, cost is also a vital part of, if at all, updating. But again, physiotherapy is fairly simple. It can be active or passive. So it cannot give, we cannot have something revolutionarily, drastically different than what it used to be. Um, so I would be careful when you are trying to add something as advanced in your repertoire, right? Uh, at the same time, I'll also ask about the physiology of what is happening. A lot of people miss out on that. A lot of people think that whatever physiology the expert or the certified instructor is telling me is actually true, which most of the time it is not, because they have to teach it in such a way then only it will make sense. There will be other hundreds of criticism or other point of view, if you will. So you need to go and see the physiology as a whole. Say, for example, if they are saying that this stretches this structure, right? If you do this, it will stretch this structure. Then you need to go and read whether the structure is stretchable, what is the physics of it, what is the tensile strength of that structure. Whatever happens, if I stretch it, if I leave it, what will happen? Will it come to my original homeostasis, or what is the half-life period of that? How long the change happens, right? These are the questions I will always ask. Um, Remember, whatever you do to your system, it will come back to your equilibrium, right? Your homeostasis. So how long the effect is vital question for us to ask before jumping on to the new bandwagon. Sorry, your mic is.
Yeah, how to validate a book, sir? Because for given condition, we have a lot of books to read. What are the salient features that Hariom sir look into before reading a book? Before reading a book, in the sense, because once we read the book, we know the content of it, we can validate it. But before reading, what are all the prerequisites you see?
uh, um, uh, uh, Nowadays I'm not reading much of textbook, but anyway, the uh, the author definitely has a great value for me. This is not scientific exactly, but I want the author to be uh, either a wonderful clinician or a wonderful academician. That will be my first criteria. And I need I would always look into the reference part of the book. It's not that more reference is better. It's just that the references should be, if it is a book written and if it has been published today, right, in 2000, uh, I will look for whether the reference is in the last 20 years, right? Most of the reference, not necessarily all the reference, but most of the reference should be in the last 20 years, if you will. And these are the two things I look for the face value of. Uh, but at the same time, I also want to know whether um, I want to uh, invest so much of time on a particular book, right? For that, I need to know whether this is very important for my understanding of medicine. Say, for example, Anish Ambekuk's Motor Control Theory and Practice. I've been reading it for probably 5 to 7 years, I suppose. Why did I put so much of effort into that book is because I knew that that book is going to help me in understanding a lot of things. And I also go into the references of where they are quoting into, right? I also read like that also. So you need to know whether this book is, for example, in your area of expertise, and so whether you want to invest so much of time in that. Otherwise, because a lot of books need a lot of time for us to understand it completely, as you can very well vouch for it also, I suppose.
Great, sir. Sir, do you think physiotherapy is all about only exercise? Because the most common criticize people do on evidence-based practices, these guys will not encourage anybody. They will discourage any interventions. So one person from Pondicherry has asked, sir, are physiotherapists limited only to exercise based upon your claims?
No, as I told you, there are two types of physiotherapy. One is active, another one is passive. Naturally, active will be more better than passive therapy. There is no question about it. That doesn't mean that you are not saying that these should not be given. It might be better all most of the time. Evidence also seems to suggest that, say, for example, whatever manual therapy you have, it seems to be having lesser value than exercise, right? But what we still don't know is whether we have to give it together, is it slightly better, right? And that kind of things are still not very clear, right? But physiotherapy is mostly about exercise. I understand, but that is not the problem we have in case of evidence or in terms of physiotherapy practice. Because, say for example, we have some understanding of what exercise can be better in ONE or in LBA or stroke or things like that. That is not a question anymore. What is the question nowadays is how to make them do it, how to make them do for 6 weeks, 8 weeks, uh, without supervision, without getting bored, or without that is adhering to the exercise. Those are the things which are getting more focused nowadays. So I think physiotherapy will be active, passive, as well as a lot of cognitive therapy, which is focused on increasing the enabling the patient, if you will, to put it in a single word.
So great, sir. Sir, what is your take on these feel-good factors, where patients are cognitively whether attested by these feel-good factors when we are giving, like for example, massage and any other techniques which gives a feel-good factor? What is your take on it?
That's all right. If you have a AC at your clinic, it's a feel good factor. If you have a uh, sort of a gently spoken receptionist, that's a feel good factor. All these things are vital. But in terms of massage, or you do something for 20 minutes, 30 minutes, you feel better. Uh, the again the question you need to ask is how long is the feel good factor that for? Is it for 1 hour, 2 hours, or is it a long term? Or also, is that feel good factor actually making my patient recover better or achieve his goal in the long term? If you are just looking for feel good factors, massage will be in the topmost, if you will, right? But that is not why our patients come to us. Feel good factor is just a part of the package, if you will, being courteous to your patient, answering everything, making them feel comfortable when they are uh, sort of half naked in front of you, when they are showing uh, their the innermost fear they have about their back or neck or things like that. So making them comfort, these are all vital. I'm not denying that, but that is more important rather than just looking into. That is one part of our treatment rather than looking into only feel good factor as a treatment. Especially that makes our patients dependent on us. They don't. It doesn't make us enabling them. So that is the um, the tightrope you need to walk.
Sir, almost functional training has started in the other countries somewhere around 1984, 85 when the Karen Shepherd have started the propaganda. But why all these things take so much of time to enter into India? Because whatever we are educating people now has been educated 20 years back. So still we are finding it very resistant to educate to our people. And why it takes so much of time to travel?
Uh, Actually, I would like to disagree. In the West, also they are struggling. Nobody is doing functional therapy or things like that. What it means is everywhere the resistance is the same. Resistance to newer knowledge, which are more evidence based. Um, because ultimately, in lot of places, right, other than in some parts of Europe, in a lot of places, medicine is business, right? So whenever the system is telling you that, or the evidence is telling you that you have to enable your patient, right? More they are involved, more they understand, more they are not dependent on us, then it is better for the patient, right? But the problem is, then my business is coming down if I do that. So that is a major resistance. A lot of people keep on saying, okay, you are saying that, okay, I have to make them walk. What do you think I should be doing? Who cares what you should be doing? You are there for your patient, not for yourself, right? But at the same time, as you can imagine, you need to make money to practice physiotherapy, because it's not social medicine here properly. It's half and half, and it is getting worse and worse. That is the reason I think a lot of things are not uh, real evidence is difficult to seep into our systems. Not here, everywhere. Probably it's better in UK and Scandinavia. I suppose, I'm not sure. Um, One of the reasons is because it's social medicine, so they have to do what the guideline is saying them to. In Netherlands, the guideline says that you can't do a NDT, right? Because there's no evidence, so they will not give you money to, or or they will not allow you to do. So that cannot happen to you and I. I can do whatever I want to my patient because they are giving me directly money. So the lack of audit also is, or uh, that kind of, okay, this is the evidence, this is how I have to practice, is not governed by anything except for financial gain. So it's uh, difficult to get it into our people. And the other thing is, um, not just in physiotherapy, in medicine itself, you, if you ask any person from Western countries and the developed nation, everybody has to do CPD, right? Every year they have to renew their license, or 3 years once, 2 years once they have to renew the license. They have to read or do CPD courses to renew the license. If you are out of practice for 5 years, and then again you have to do lot of renewal to again start practicing. So that might help in keeping them updated. Might. I'm not still sure, because continuous medical education has very, they don't impact as much as we used to think. So that kind of things we don't have. That is, we don't read after finishing our exam. Even in the internship, people don't read, right? So that might be one of the reasons why people don't want to read. There may be a lot of reasons. These are the simple reasons I can think of.
Yes, sir, you're correct, sir. Yesterday, I got a call from a student who said somebody taught him that vigorous exercise means giving 200 passive movements. That is vigorous physiotherapy. So I was also laughing. Sir, next question is very practical question, sir. See, if somebody is conducting a webinar or a course which is having pseudoscience, and we are very sure that this is going to contaminate the minds of the budding therapist, how should we react? uh, because nowadays in a normal scenario, we react too much to them because we tag them on Facebook and straight away take up the resource person and tag few of very particularly they will tag Hariom sir, Prakash sir, and Sivakesavan sir, and a few more. And this trend is like we are trashing people, thinking that they are only money minded. But how to deal with them, because some of the free webinars are also going on which are dealing with some pseudoscience, but how to practically inform that this is wrong?
Like, I have tried every method you can think of. Before Facebook, nobody was thrashing anybody. I have told them, uh, but also I have not reacted to a lot of places where I have been tagged also, because of two things. One is, uh, sometimes what happens is, if it is if it is science and if they are asking a lot of money, I don't mind. Uh, you can charge 1 lakh. Who cares? It's not my money. It is up to the student whether they can pay or not. I really don't have any standing in that. Right? It is, say for example, you want to go and read functional therapy, if at all, if you, and somebody is charging you 1 lakh. Why do I bother about that? That's not my. Uh, there's no take in that also. Uh, but where I get slightly offended is making students go because you get a commission or something like that. That is, I think that is where I get seriously offended. I just start thrashing them, because you are pushing them towards something where, because you are getting some benefit out of it. It doesn't have to be financial benefit. It might be any benefit. He might be your friend, so you're sending them to that kind of thing. I think that's a no. For that, there are some good methods I have heard also. Say, for example, in some colleges, some universities, what they have told is you can only put the poster at the notice board. You can't go and tell it to the students. You can't tell them that you have to go. You can't tell them anything. You can just put it on the notice board. That is all, right? I thought that was a wonderful method, but whether it will work or no, I don't know. Well, so that kind of things can be better. Uh, but the simple solution I can think of is to educate the student that these are the things you need to understand. These are the things which are vital for practice. You don't have to spend a lot of money to understand simple things. That kind of things are vital. And also, even if it is a free webinar, I don't think you can teach nonsense, because it is not that knowledge is just going to be inside. It's not like history where you blabber whatever you want. Where it's going to be in your mind. But here, if you tell them that, as I said, 200 passive movements for a person, even if you teach it for free, it is going to be hurting the chances of your patients getting better, right? So ultimately, the patient is the king. If you are not, if you are not having that in your mind, you should not be in medicine. You should not be in healthcare. Nobody cares if you uh, sell a popcorn for 200 rupees, because it is just money. You can sell it for 200. Who cares if they sell it? Don't buy it in the who's telling you to go and buy a popcorn in the theater? People are just worried about something which is of no. But here it is just like hydrochloroquine. They were promoting that, and we know that it is of no value. That is the problem. Even if we give free advice, even if we give free chloroquine, if it is a dangerous drug or it's not a useless drug, it ultimately affects the patient's recovery. So I think they have to be dealt like that. A lot of people don't understand that. So if you don't understand, uh, sometimes the stick is seems to be needed. But the best answer might be that we need to educate our students in such a way, and also say with a big, I mean, with a sort of, uh, I don't want to say it, but I have to say it. The staff and the principals have to behave like uh, teachers, not like right.
Sir, a few personal questions, sir. Personal question in the sense that one I have added. Sir, please elaborate about the use of voluntary control training, voluntary control assessment, not training, sir. Voluntary control assessment in stroke patients in case of the presence of spasticity, when we are not able to do an isolated movement where the definition of muscle power itself is against the gravity or towards the gravity, full range of motion, isolated muscle activity is a definition. So how apt it will be to do a muscle power examination in case of a stroke who is dominated by combined movements?
That's all right. You can do muscle power. That's not a big deal. The problem also is uh, muscle power assessment is also voluntary control. There is no difference between voluntary control and muscle power. It's just a different word we are using. So the point is, uh, the uh, what is that you are trying to take from this assessment is what is very, very important. Right. So if you are trying to understand whether these muscles are weaker, you can do it like you do it for any condition, especially element lesion. But as you can, as a lot of people might have studied, MRC grading was done or started for when there was a polio pandemic, right? So it's commonly used in element lesion. That doesn't mean that it cannot be used in. It doesn't mean that we cannot use it in human lesion also. We can, and there are a lot of, I think, up to number of studies which has shown that they are reliable. Especially with handle dynamometer, it gives far better value. But again, the last question it comes to is, what are you going to do with that? Because we know that if you have a lot of strength, that doesn't mean that you'll walk better. If you have less strength, it's not that very clear, but there is some amount of correlation, but it is not very clear, right? So, so to uh, but there is no test called as voluntary control test. That's a Chuma nomenclature we just added to that because MRC scaling is a voluntary control with one parameter, that is gravity as a parameter. Because if you are mostly, what does your muscle do is muscle produces force. It doesn't produce voluntary movement. It produces force, right? That is the one thing you can measure. You can't measure voluntary control as such. You can just measure force, right? For the force to be measured, you need a parameter. For that, you can either have a handle dynamometer, which gives you in terms of weightage or something like that, how much of the spring is compressed or things like that. Or it can be the gravity as a parameter, right? So that is the simplest way to do it. MRC scaling is a better way to do it. But what we want to know is whether I can touch an object like this accurately, or whether I can hold an object. Those are the things which we think that it gives us better understanding to formulate a better treatment, right? So that I can, if I'm not able to touch it properly in the right place, I have to improve that kind of understanding. So that's why we have moved on from impairment level assessment to sort of a functional assessment, which is basically a combined movement rather than single joint.
So rather than quantitatively rating it, we can go for qualitative rating. We can qualitatively describe the movement.
Yes, if that is what you are trying to measure. Say, for example, when you're walking, you can qualitatively say that in this posture, that is in this phase of the gait, the hip goes into 20 degrees of abduction, and the knee is in 10 degrees of flexion rather than 30 degrees of flexion, and that kind of thing can also be done, right? If you are trying to improve flexion of the knee and reduction of the adduction also in the hip joint. So it depends upon what you are trying to correct. You can measure like that.
Sir, your take on the Brunstrom's grading?
The 6 levels of grading.
Yes.
It has some amount of validity in the stages, but it gives you very little to plan a treatment. It's difficult to plan a treatment with that particular level of functioning or things like that. Because if I am able to move against the synergy or within the synergy, it doesn't matter, because a lot of people are able to do with that itself, right? That is the marvel of the human body. We see people who are in Paralympics, they do everything in a far more different manner. Nobody does in a normal manner, right? But they do things which you and I cannot do, right? You and I cannot do the high jump they are doing with just one leg, right? So it is not giving you a clear-cut understanding, because what I'm trying to say is you formulate a treatment depending upon your current ability, right? If you are in 5th standard, you know that this is your ability, so you will go to set theory and algebra as you get older, right? So that for that current ability, what is my current ability to understand, Brunstrom classification has very does not give you the necessary information it needed.
Sir, but can we use it for defining our patient in case of using it as an inclusion criteria? In an inclusion criteria, can
Again, not necessarily, because we don't know whether that led to better ability or lesser ability. Right? Say, for example, a patient may be having very less against that is moving away from the synergy pattern, but they may be able to do a lot of work. At the same time, the opposite may also happen. A lot of people may be moving away from the synergy also, but they may not be able to do a lot of activities also. So it is better to tell us, okay, what is the current ability of your patient? But it can be done. It gives you a good idea, right, about what is your current level of your patient also. It's not completely no, but we have to be taking it with a pinch of salt.
Thank you so much, sir. Thank you so much for your time.
Thank you.
Yes, sir. Great day, sir.
Bye.